Yes, Jeffin.
Yes, I don't have question as of now.
As of now, there are no questions because it's about anatomy, and please, explore yourself. You might have attended any cranial course before. Have you?
No, just the anatomy, in school. So
Okay. And you have a skull there?
yes, I have.
Yes. Okay. Can I see your skull? The model which you have there? Can you show it more closer? Yes, I think it's the same as the one which is here, without the marking. Okay. So it's much better and easier. Okay.
Yeah.
To have it. And did you have in between the curiosity to watch the cranial neuromanual therapy?
Yes.
Yes. Okay.
Yes.
So, did you watch the facial or the trigeminal? Which one did you watch?
Actually, I'm focusing to the videos. There's lots of videos in FOMT. So I'm just scanning
FOMT
for
is too big. You don't start watching FOMT now. Okay. So you should watch the cranial neuromanual therapy. Okay. And keep the FOMT. Okay. I want you to get to FOMT videos like you have a patient of neck pain, you want to get an answer. For example, it's a myofascial pain syndrome. You're treating a patient. Then see the masterclass on myofascial pain under the cervical spine specialist. Okay. So like that. Okay. So don't go for the FOMT now. Okay. And see that go phase wise. Okay.
Yes.
Right. And use it clinically. FOMT can be useful clinically. You have a low back pain, see the lumbar spine specialist. Spondylosis, a patient has come, watch the spondylosis video, and then go ahead. Okay, so those things you can do parallelly, but don't start FOMT A to Z by watching first the CSMT, then CS cervical, then lumbar. Nowhere. Okay, and if you start like that, you'll spoil your new year. Okay, so you can't enjoy this new year. You'll feel like, oh, I have not finished anything. Okay, so right, so clinical reference. Okay, so like that you use the FOMT. Okay.
Yeah.
Here for the osteo manual, make sure that cranial neuromanual therapy is more. It will make the cranial osteo manual easier. Okay. So that way, right? Because we know cranial nerves and we know their actions, sensory and motor. So how that techniques are incorporated together, okay, with the cranial osteo techniques, okay. So the techniques that are demonstrated there in the CRNMT, the osteo techniques are very simple techniques. Okay, so easier to understand. Okay, that, right? Making coffee, then having coffee. Yes, Dr. Darshana, go ahead.
So fantastic session today, because I always wanted to really understand, seeing this osteomanual therapy, what they do exactly. And today what you have given us really a glimpse. Definitely we are waiting for the further sessions to be conducted. But I'm feeling very happy that I'm actually learning what I wanted to learn last so many years, because doing those 6 months, 2 years course is not possible. And more importantly, you are teaching us from a physical therapy point of view and evidence-based. So that is really very interesting. And I'm really looking forward for the further sessions. So
even a neck pain also, just to see the rhythm, neutral, rotate, after that see the rhythm. Okay. So if it is foramen, extension, rotation, then see the rhythm. So see for which is the challenging position, and in that you see the craniosacral rhythm. Unless you find a difference between at rest and the position, don't do cranial technique.
Okay.
Understood. So there is a reasoning, there is an indication here, which is more logical and very sound. compared to just seeing an asymmetry and then keep treating that, and you are holding the head and you are sitting and the patient is happily sleeping. Okay. And after 30 or 40 minutes, patient will definitely feel better because they slept nicely. Okay. And anybody holding your head, okay, you know that even in extreme situations of depression also,
Yeah.
you keep like this, we'll feel better in 10 minutes. Okay.
Exactly.
So anybody holds the vault, it is also called as the vault hold. Okay. So you just hold it and the subject lies down. Definitely they will get better. Okay. So there's a lot of things to do with the placebo or the positional relaxation and all those things, because we are telling the patient to focus on breathing, awareness of breathing. And we are also focusing on the breathing and the skull movements. So I really admire the people who tell that they attend a cranial osteopathic course on day one and they tell that, yeah, I'm feeling the suture movement. Okay. So really, I'm fascinated by those human beings. Okay. Let's see. Okay. So, but the research has not proven any kind of reliability in the skull bone movement in any of these bones assessment between people or even the same person evaluating the skull without knowledge that on which patient. Okay. Patient is blinded. Okay. So only skull is visible. Subject is held and then evaluating 10 subjects, having a finding. After half an hour, again evaluating. Other ones, everything repeating. The first subject, what was the first finding is not the second finding. Same examiner. Okay. So intra-rater reliability is also poor. Inter-rater is also poor. Validity with the motion sensors they kept in the skull, and they also couldn't get any kind of kinematic validity. Okay. So that is why I am telling in terms of the kinetic aspects and the functional neurotransmission and neural circulation. So trying to see with contrast CT or functional MRI during the technique. Okay. So that is how we are trying to improvise and validate. Okay. And of course, the impairment based evaluation where upper limb loaded, then seeing the craniosacral, okay, versus offloaded, then seeing the craniosacral. So these kind of reasoning should come, okay, like regional interdependence. Same way it is a what is called as a functional interdependence. Okay? So one is for parasympathetic sympathetic control, other one is for actually for somatic. So everything is important, and most importantly the central pain mechanism. Okay, people who have chronic pain and fibromyalgia, those who have substance P in the CSF, okay, they have that. Okay, all the chronic pain, the central pain. Definitely, they will be hugely benefited with craniosacral therapy. Okay, so you should see in terms of be it placebo, no problem, but definitely the kinetic part should not be ignored. Okay, so that is the one which should be focused. Okay, rather than the kinematic side.
Wonderful. Thank you so much, sir.
Yes.
After doing the CRNMT course, like we could relate it much better. Like today, whatever, and today's session was more in details. You know, the anatomy, we could understand better what you had taught.
I know another 1 hour it will go detail. I have to reassemble this. Okay. Yes. I'm still having a doubt whether it is part of the small skull or it's part of the big skull. Okay. So is it I know foramen magnum is there, so it is occiput. Okay. But there are other bones which are like very, you can see this one for example. Okay. So this is like a smaller part of the bigger skull, or it is the palatine and the vomer of the small skull. Both are there. One more thing what I wanted to highlight is the difference between male skull and female skull. Okay. Yeah. I have kept the skull here. Can you see on the surface? And you can see a big gap here.
Yes.
Okay. So that means it is like male skull. Okay. Male skull is more rectangular. Okay. So that means here also, and then it is rectangular. Okay. A female skull is triangular. Okay. So it's broader here, goes down like this. Okay. And when I keep it on surface, you will find flat,
Yes.
resting on the surface. Okay. So this skull is actually a female skull. Okay, the colored one. Okay. That is the reason getting disconnected so fast. Differential diagnosis. And yeah, okay. So this skull is the male skull. That's the jaw of another bone. Okay. Yeah. And I want to see the gap. Okay. That is the male skull. Also, the zygomatic is more prominent in the male. Okay. And these are all very characteristic. And if you see the lateral aspect, the frontal, okay, is more vertical than oblique. Oblique means it is female skull. Okay. So I can share some of the picture of difference between male and female. Here. All photos. So what we have here, contour of the face. Can you see this triangular versus the rectangular? Okay. Zygomatic being prominent. Okay. So this one here also rectangular. Okay. And you can see here smaller and triangular. Okay. So these are something which you can notice for male versus female skull. Another picture in the album. Sorry for that. Switching albums. Photo gallery, albums, all photos. In lateral view also, you can see the female skull here. Okay. In another aspect, I want to get you focused. See here, this is a straight line. Okay, in female. Whereas here, okay, so there's an angle there. Okay, so what I want to tell is in female, the sphenoبasilar junction is flexed. Okay, in male, sphenoبasilar junction is extended. Okay, so that's something for the osteomanual therapy. Okay, so you can see that sphenoبasilar junction flexed. Okay, compared to this. Okay, so easy to remember. Flexed sphenoبasilar junction, F, female. Okay, so and because it is flexed, it is kind of sitting flat on the surface. Okay, so if it is extended means then definitely it will not be sitting flat. Okay, so the skull what Dr. Ritu ma'am is having, can you show that? Identify that whether it's a male skull or a female skull. Absolutely, she got the male skull. So you can see that the gap that is there inferiorly, okay, and the rectangular face, the front, anterior. Can you show the front one? Okay, so it is again rectangular. Okay? So it's a male skull. Skull. Okay, so remember that these things will have again influence. If the sphenoبasilar junction is already flexed, it will have an influence on other dynamics, okay, rather than a neutral sphenoبasilar junction. Okay, so there are a lot of things which has to be individualized and patient-centered application. Okay, so this is what I am also exploring as I am going across the literatures and trying to get a what is called as the juice. Okay, mixed fruit juice. Okay, yes, Ritu ma'am.
Yes, sir. Well said, sir. It's going to be a mixed juice, and I think for this course, I wanted to say that we are learning the crown of our body, the skull. So this course will be the crown of AMPT the year 2021. Okay, this will change our complete view how we can treat this type of patient also, where we are not able to touch, we are not able to palpate the tenderness, we cannot check. But after, I think, these sessions, we will be more confident to treat this type of patient also, where the skull importance are coming. We just feel that we cannot do this, but I think nothing is impossible in UMPT. So we are going to learn, this is a very great course, and we will learn more about the skull and their sutures, everything. I think there will be a great view full, because today that short picture is very much interesting, so that the full movie will be more wonderful, I think. And today you
Because the
have shown.
palpation exercises, as today I told you for suture, for example, tomorrow you will get to know some other palpation exercises, which will be like different positions. Okay, palpating in lying down, palpating inside. Okay, when the pressure is there, other side when you are lying down, and then you are palpating here. Okay, so there are a lot of things which will be self-listening. Okay, and definitely you will get that bigger picture. Okay, so the difference in kinetics. Okay, so this is what I want you to feel. So make sure that your line of thinking goes in that direction. And of course, the future case reports, case studies, and full route for evidence. It's important as physical therapists.
Yes, sir.
Right?
So I think it will be very, like, today you have just divided into three parts, that vault, base, and skull, the frontal area. Then how we can check the landmarks that you have shown, the heavy words which are like just like scientists to name. So we have to learn it
Yeah,
more
see,
about
there are a
that.
lot of other things also there. Other than this, even the foramen have everything have a name. Okay. So each one has a small prominence, a protrusion, tubercle here and there. Okay. So what's important is clinical when it comes to anatomy. And anyway, we are going to see. Okay. See, I'm going to organize the master classes like for cardiopulmonary disorders, what are the craniosacral? For neurological disorders, which is upper motor neuron, what are the craniosacral? Cerebellar lesions, what are the craniosacral? In peripheral element, so whether it is a spinal cord or it is the nerve root, cauda equina, or is it the nerves, peripheral nerve injury. So for that, what could be the craniosacral techniques? Okay. So like that, I'm going to organize the clinical part. The last 10, okay, master classes will be disorders. So visceral disorders. In visceral disorders, what are the craniosacral? Depending upon the homunculus, the sensory and the motor representation, and so, and some like hypothalamus and all, they are related to the genital organs. So base of the brain. So like that. So we're going to get an interlink and see that gastrointestinal disorder, what could be the craniosacral. So these are all. Anyway, visceral is going to come, that is specific for the each of the systems. But here, the cranial basis of visceral dysfunctions like that. Okay, so that also comes. And even back pain and neck pain, as I was highlighting today, or even the upper limb or the lower limb. So irrespective of people who have central pain or not, still cranial dysfunctions, kinetic abnormalities are found. Definitely you can treat, because it will help in a faster healing because of the parasympathetic influence. Okay, so that is how we need to think. A better thing which we can do by additional another 40 minutes maybe, because craniosacral will require minimum 40 minutes. Okay, 1 hour dedicated. The environment should be perfectly sealed off. Okay, there should not be any noise, no disturbance. Absolutely, patient's caregiver can sit inside, and maybe your assistant can sit. Okay, so now it has come with various what is called as tools. Okay, to note down the rate, craniosacral rhythm, and all those things. But still, they are also not proven to be valid. Okay, so with the markers and sensors in the head, subject is made to lie down to see for that. Okay, so think of relating the physiological and the biomechanical interlinks. so that we can treat musculoskeletal, we can treat every disease, psychiatric also. So there are like regions of the brain for various functions. So for them, that region, what could be the dysfunctions and what can be the treatment for a person who's having an anxiety versus a person who's having bipolar disorder, for example. Okay? So a lot of things could be brought out, and it will be like a visit to space. Okay, so it's totally out of the world. Okay, it's not just out of the box, and it is out of the world. Okay, so this is what we are going to see, and definitely you will enjoy the course as you always do in every course. And of course, your presence makes me to give better and better courses. Okay, every time, like Ritu Ma'am and Darshana.
Thank you, sir.
Definitely. Okay. So we are ready to close the session today.
Yes,
Yes,
sir.
sir.
Dr. Shagira is not coming on screen. Okay. Yes, Jeffin. So see you. Bye bye. Good luck. Okay.
Bye.
Darshana ma'am.
Okay,
and
good
Ritu
night.
ma'am.
So, Hare
Yes.
Krishna.
Bye, ma'am.
Bye.
Bye, Jovan sir.